I know it's Friday afternoon, you've been here for a long time, so I'm going to try and make this as brief and as uncomplicated as possible. Patrina, in her naivety, or I'm not quite sure how to describe it, took on to do 5 Cochrane reviews. And I'll just give you little brief glimpses on each one, because I think 10 minutes for 5 reviews is quite difficult. So the reviews that we've looked at and that have... Sorry? So the reviews that we're looking at is drugs for enuresis in children, and that was done by Arnie and Patrina, simple behavioural and physical interventions, tricyclics, that one is currently in press. I'm looking at the one on desmopressin, and the alarm interventions is also currently underway. So just to give you a little bit of background as to what's involved in an actual Cochrane review, because it is quite an arduous process to work through the whole thing. Usually there's several groups throughout the world who will approach you and who are involved in doing your searches. So ours is done through the Cochrane Incontinence group, and they will identify all the trials through a special sort of register they have to have a look at trials, and they'll go through Medline and clinical trials. They also do hand searching of journals, and will go through conference proceedings and different things. So that we really have, for that time, for that search, the most up-to-date sort of information that we have. Importantly, all the trials are randomised controlled trials. We may have a few quasi-randomised controlled trials, and generally we focused in children sort of 6 to 16 years of age. 1 or 2 trials may have children slightly older. Importantly, our inclusion criteria is really just to focus on monosymptomatic nocturnal enuresis, and trials that just focused on daytime wetting on its own or on adults alone were excluded. A few of our trials have got non-monosymptomatic, so if they've given results for nocturnal enuresis, those were included. When we go through data collection and an analysis, that's usually done by 2 authors, just so that you can compare the data and make sure that we're both extracting the same data, and that all the trials that you're deciding to include have been verified by both authors. And then there's the risk of bias assessment, which I'll discuss a little bit, but that's really just to see how good the methodology of the selected paper is. So the outcomes that are assessed and that we look at and report on are the mean wet nights on treatment, and for this you really need to know also what the baseline wet nights are. I often find the sort of phrasing of this a little bit difficult, but that's the way they've decided to word them at the moment. Number not achieving 14 consecutive dry nights, and that's usually actually at the end of treatment. Mean wet nights at follow-up, so once treatment is finished and the patients are returning, then it would be patients relapsing and adverse events. And just to give you a little bit of an idea of the risk of bias, so that we know how rigorously a study has been done. Importantly, to look for any selection bias, we need to know how the study was randomised. So have we got information on that? Is it computer generated? With the allocation, have they used sealed envelopes? How have they allocated the patient treatment? Performance bias. Do we know if the patients and parents were blinded, if personnel was blinded, and the people assessing the data, whether they had any idea of the potential treatment? Attrition bias is just to give us an idea of the number of patients included and how they were followed up. Was there loss of follow-up after randomisation, and whether these patients have been accounted for? And reporting bias is really looking at whether they've included everything in the trial regarding outcomes. Have they reported all the outcomes in a way that we can use in meta-analyses? Have they included appropriate statistical methods? Have they included things like adverse events? And other bias would be just, for example, if a trial was funded, so that there may be possible bias in that sense. So to start with the drugs for nocturnal enuresis, this is a trial done by Arnie, and that included 40 RCTs for the update that he did. There were 10 new studies. There were nearly 2,500 patients, and 1,700 received the active drug. There were 31 different drugs that were used within the trial. A lot of them I've not even heard of. But what's come through, and I think what's come through in many of the reviews that we're doing, is that many of them have small numbers and have poor methodological quality. So that's sort of all the things we've mentioned in the risk of bias. And many, there's an overall paucity of data, specifically for patients at follow-up. And adverse effects were also poorly reported. But within those, when we looked at drugs versus placebo, so for a host of different drugs, we do find that using the different drugs compared to placebo, you do seem to reduce the number of wet nights. And importantly, and this comes through in many of the things, is that when we're combining the drugs with an anticholinergic, we find that there's a significant improvement. In drugs versus behavioral therapy, we find that bedwetting alarms seem to be better. And as I've mentioned, there is an overall paucity of data. In the review, looking at simple behavior, so this would be things like lifting the child, bladder training, just to try and decrease wetting. This was a smaller review with 16 trials. We had just about 1,500 children. And what we found that many were just addressed by single trials or single centres and also just single arms, so that you couldn't really do an adequate meta-analysis on them. The ones where we could include data was where we had bladder training versus enuresis alarms. And then we found, obviously, that an alarm was superior to just lifting techniques or bladder training. So in single small trials, rewards were associated with fewer nights, but they obviously have a higher rate of relapse. Simple behavioural interventions are less effective, obviously, when we compare them to other things such as drugs and alarms. But this is probably one good way to start. If the child hasn't been referred to a centre yet, you can let the parents know, start with things like lifting behaviour therapy and urotherapy, which you've all heard about, I'm sure, so far today. And when you compare different behavioural therapies, one wasn't really any better than any other. For the tricyclic review, this was quite a large review, a large update, and we had 64 RCTs with a large amount of children. And once again, we're finding that many of the trials are poor quality or single-centered studies or single-arm studies. What's important is that with the tricyclics, there were very many adverse events reported. Many of the trials didn't report them, but obviously, with a drug, you're going to have more adverse events, but not sufficient to stop the drug. Most of them were of minor consequence. Sorry, this is a bit small and busy, but I'll just walk you through it basically. So when we compared just tricyclic therapy on its own with desmopressin, the results were similar. There was no significant difference. When we compared imipramine on its own with desmopressin and an anticholinergic, we found that the combination therapy was much more effective, and this is a theme coming through. Tricyclic therapy on its own was much less effective than alarm, and we found that alarm therapy has a much more sustained effect, especially after ceasing therapy. Imipramine is more effective, than just anticholinergics. Where am I? Imipramine is more effective than simple behavioural therapies. And once again, our combination therapies are more effective. If we combine imipramine and desmopressin compared to desmopressin on its own, once again, our additive effect of desmopressin and imipramine is more effective. And our tricyclics compared with alarm therapy versus just alarm therapy on its own, there was no significant benefit of comparing the tricyclics with alarm therapy. So the review I'm currently busy with has got 72 randomized controlled trials with 20 new trials that we've added. And they're well over 6,000 participants. Once again, we're finding that the older trials have got poor methodological quality. Many are single-centered studies. With the newer studies, we're finding that many more of them are multi-center, so that's giving us much better results. And again, we found that the adverse effects are poorly reported. So the comparisons we're looking at is desmopressin versus placebo, and certainly we can see that desmopressin is better than placebo on its own. Desmopressin versus desmopressin is just really looking at different formulations of desmopressin, so oral versus nasal versus melts, and different dosages of desmopressin. Looking at it versus other drugs is, as we've mentioned with some of the other trials, comparing it to the tricyclics or anticholinergics. And then we've also looked at desmopressin versus alarm, and then also combination therapies. And as I'll show you, this seems to be where our major results are, that combination therapies are the way to go. So just to give you a little bit of an idea of what our risk of bias looks like once we've charted it in a Cochrane review. Really green means good, so that means there's low risk of bias. So there we know that they've randomized them adequately, they've allocated adequately, and we've got good blinding here. And red just means that there's high risk, so those things are poorly done. A lot of the studies we found are still unclear, so those things aren't reported adequately or aren't performed adequately, and it would be good to see improvement, obviously, in those areas. This is actually from Arnie's trial, but briefly from what we found in the desmopressin one as well. We are seeing that our combination therapies, so more so with anticholinergics, with desmopressin or versus alarm, we're getting a favor of our combination therapies. So our conclusions for the simple behavioral methods, they seem to be superior to no active treatment, so not doing anything at all. Just giving simple behavior seems to help a little bit. And as I've said, that can be used as first line. And our overwhelming thing that we're seeing in all the reviews is that combination therapy with an anticholinergic seems to be the way to go. And we seem to, and specifically with relapse rates, where we haven't got many reports, that seems to improve by about 20%. Tricyclics are also effective in reducing the number of wet nights, but do not seem to have as a sustained effect, and many children relapse after therapy. Alarm therapy seems to have better short-term effects as well as long-term outcomes, and I think that would have been shown in the trials. So thank you for your attention.